Welcome to the Deep Dive.
Glad to be here.
Today we're diving into a topic where what's on the official record and what people are actually talking about are just, well, they're miles apart.
They really are.
We've gathered this incredible stack of material regulatory filings, market analyses, scientific papers, and they all point to one thing.
This whole ecosystem of wireless body area networks, remote patient monitoring, and, this deep biocyber infrastructure that's been quietly built for decades.
And that's the core conflict in all this material, isn't it?
Absolutely. On the one hand, you have this common skepticism, even from professionals, just an outright denial that this kind of advanced connected medical tracking is widespread.
But on the other hand,
You have meticulous, decades-old documentation, federal and global standardization and deployment of these exact systems. It's a huge discrepancy.
so if it's all right there in the documents, why the confusion? What's the cost of that gap in understanding?
Well, I think that's our mission today.
Right. For you, the listener, we want to cut through all that noise. We're going to take you directly into the timeline, the hardware, and the, frankly, massive financial scope of this infrastructure.
So you can grasp just how established these systems really are.
Let's start right at the beginning, the regulatory paper tray. Because the timeline itself is probably the most powerful piece of evidence here.
It really is. We have to look at the foundation of the Medical Body Area Network, or MBAN.
And we tend to think of this stuff as, a recent thing, a post-smartphone phenomenon.
But it's not. The infrastructure for MBAN was available and being publicly discussed on fcc.gov as early as 2012.
2012.
Yes. We have docs showing executives from GE Healthcare, Philips, George Washington University Hospital, all talking about the rollout over a decade ago.
That's amazing. And it wasn't just talk, right?
No, not at all. It moved to mandated action very quickly. Yeah. The FCC issued a final rule for MBN on October 6, 2014.
A final rule, so that's law.
That's law. In technology time, 2014 is ancient history. The legal framework was set long before the smartwatches and fitness trackers became, a part of everyday life.
And to make that rule actually work.
A year later, November 2015, the FCC authorizes the Enterprise Wireless Alliance to be the official frequency coordinator.
The coordinator. So they're like the air traffic control for this data.
That's a great way to put it. They were assigned the 2360 to 2390 megahertz band, a serious piece of the spectrum dedicated just to medical monitoring.
And this is where the compliance part really kicks in.
Exactly. These coordinators weren't just handing out channels. They were legally required to maintain a detailed database.
Of what specifically?
Of every single MBN transmitter, its location, its operational parameters. This was not a suggestion. It was mandated oversight from the very start.
So the implication there is pretty clear.
It is. Major organizations, the American Hospital Association, any facility focused on optimizing healthcare, they've been mandated to understand and comply with these standards for years.
This is not some speculative R&D project.
No, this is critical infrastructure compliance. And you have to remember the systems they were building on top of.
It goes back even further.
Way further. Before MBN, you had the Medical Device Radio Communication Service, or MDRCS. That was established in 1999.
1999. Wow.
Right. That was the original wireless telemetry for critical devices, pacemakers, implantable defibrillators. The idea isn't new. It's just been constantly and quietly upgraded.
Okay, that brings us to the next piece of this puzzle. The hardware itself. The paper trail is deep.
Yeah.
But what about the physical devices?
This is where the denial really hits a wall. Because we all know technology constantly upgrades, and medicine is no exception.
We're all familiar with the obvious stuff.
Of course, the Fitbit, the Oura Ring, the smartwatches from Apple and others, that's the visible, user-facing part of the network.
But the really interesting integration, the part that makes you question everything, is the less visible tech. The stuff that's already out there.
I think you mean things like smart pills.
Smart pills, exactly. Or e-tattoos that can monitor your blood chemistry. Smart bandages that wirelessly report on how a wound is healing.
And this isn't science fiction. These devices draw directly from the nanotech boom. The components are very real.
You're talking about the National Nanotechnology Initiative.
Yes, the NNI. Launched under President Clinton, coordinating federal R&D since fiscal year 2001. That's over 2 decades of focused government work on making things smaller and smarter.
I mean, we've seen it in the real world. Carbon nanotubes from Rice University research in the 80s?
Or even nano silver. It's already in consumer products. Antimicrobial socks, some sunscreens. The building blocks are mature and commercialized.
So the core argument here is that if this stuff exists for consumers,
then the idea that our major federal and institutional healthcare settings haven't adopted equivalent or probably far more advanced systems is, well, it's just implausible. It defies the normal curve of tech evolution we see everywhere else.
Okay, so we've got the federal framework and the nanoscale components.
Yeah.
Now, how do you manage and how do you pay for the colossal amount of data streaming from millions of connected bodies?
That takes us straight into global standardization and the money, the staggering financial drivers.
You need a universal language for all that data.
You do, and that's Health Level 7, or HL7. You can think of HL7 as a kind of Rosetta Stone for medical data. It's the global standard, and they've been working on it since the mid-90s.
So a lab in London can send a report to a hospital in Los Angeles, and the systems understand each other perfectly.
Seamlessly. And now there's a newer system building on that called FHIR, Fast Healthcare Interoperability Resources.
FHIR.
Its first draft was in 2014, so it was specifically designed to handle the huge real-time data streams from all these new sensors.
And what's fueling this build-out?
Money, just massive amounts of money. The remote patient monitoring market, RPM, is projected to hit nearly $57 billion by 2030.
$57 billion.
Billion with a B. And that growth isn't just from people buying smartwatches, it's from systematic government investment.
Like the U.S. Rural Health Transformation Program.
Exactly. Authorized by the One Big Beautiful Bill Act, it provides up to $50 billion to states through Medicare and HHS.
And that money is specifically for what?
For adopting these innovative care models and expanding the use of technology, it's a formal mandate to integrate these systems. The sources call it Healthcare 4.0.
Healthcare 4.0, the convergence of automation, biomedical engineering, and health informatics.
That's the one.
And what's the ultimate goal? The destination for all this data, all this standardization and investment?
The creation of the digital patient twin.
The digital patient twin. Explain what that is.
It's exactly what it sounds like, a continuous, updatable digital likeness of a patient.
Built from what?
Everything. Your entire medical history, your genetic data, and crucially, the real-time data streaming constantly from all those sensors, wearables, and ingestibles.
And once you have that twin, what do you do with it?
You let AI run incredibly complex simulations on it. You can predict future health problems, test out different treatments virtually, and get actionable, moment-to-moment insights.
So it's not just for advice.
Far from it. The functionality is designed for continuous monitoring, empowering you to self-manage, and, most importantly, providing automated configurations for medical devices.
Remote treatment.
Remote treatment. The sources even mention this framework, allowing for remote robotic interventions. Always under human supervision, they say, but the system is designed to act on its own data.
Okay. We've covered the standards, the money, the end goal. Now, this is where the conversation shifts.
Yeah.
From the external device to the human body itself.
The body is the ultimate piece of hardware.
Right. It's a fascinating and maybe a little unsettling conceptual leap.
Well, what's interesting here is the core premise is so simple. The body is fundamentally electrical.
We don't often think of it that way, but it's true. Every critical process we have relies on it.
Exactly. Charged ions, sodium, potassium, calcium moving across cell membranes. That movement is what generates the electrical signals for nerve impulses, muscle contractions, even tissue regeneration.
And there's a name for this whole system.
The electrome. You're already familiar with it, even if you don't know the term. An EKG monitors your heart's electrical rhythm. The electrome is just recognizing that this electrical balance, this homeostasis, is fundamental to your life.
So if you disrupt that homeostasis,
that's where you get problems. The sources are clear that interfering with these natural bioelectrical signals can lead to disease, organ damage, systemic malfunction. Your body is basically a dynamic, programmable electrical network.
Which leads directly to the next big upgrade, the bio-cyber interface.
This is the really advanced step. The sources describe it as cellular anatomical connectivity to the Internet of bio-nano things.
That definitely sounds like science fiction.
It does, but it's presented as the essential hardware layer for the next generation of precision AI healthcare.
And they've already worked out the security protocols.
To a startling degree. To ensure HIPAA compliance, the network security systems can generate random numbers for encryption using your own biometrics.
So, my own body is the password.
Your body's unique electrical signature, your heart rate, your pulse, is actively being used to generate the security key for the network. Your biodata is your ID.
And the sources connect all this to a much broader context.
They do. They link these systems directly to the purview of electronic warfare. The argument they make is, well, If the infrastructure exists for precision healthcare,
It also exists for under-the-skin surveillance.
it raises some very critical questions about capability, especially about the potential to manipulate those bioelectric signals we just talked about. It suggests a very high-level intersection between national defense and what we think of as routine medical monitoring.
So after all this, what does this mean for you, the listener? What's the main takeaway?
I'd say the sources present a very consistent, very long-term trajectory. We're seeing the integration of the human body into a secure, continuously monitored digital network. And this is not some recent secret project.
No, it's supported by decades of R&D. You mentioned remote healthcare monitoring from 1971, medical radio standards from 1999.
And it's all backed by massive financial investment, that $50 billion fund we talked about.
These systems are professional, they're measurable.
And they're directly connected to critical global infrastructure, Health Level 7, and as we noted, linked to DHS biosurveillance and even cyber command capabilities.
It really forces you to reconsider the whole public narrative around patient autonomy, just how saturated we are with this technology.
Which brings us to a final provocative thought for you to take away from this deep dive.
We've established that AI and machine learning can now legally qualify as a practitioner. They're eligible to prescribe drugs, as authorized by state law, under the 21st Century Cures Act.
So, if that's the case, what are the profound legal and ethical implications when the patient twin, which is being fed by real-time data from your own electrome, is simultaneously providing automated feedback and being monitored by that same legally defined AI practitioner system?
It essentially turns the patient-doctor relationship into a dynamic algorithmic feedback loop.
A loop controlled by algorithms. Think about that.